Welcome to this month's OHT webinar, 3 years in. Please go ahead and introduce yourself in the chat. Some people might be used to this already. And go ahead and let us know who you are. And I look forward to hearing from you. So type into the chat. Please make sure that your response is set to everyone. And let's join in now. Nashaba, welcome. Anita Tressler from Sarnia Lambton, welcome. Stephanie from Western New York. Kathy Peters from Burlington OHT. Mike Heinmarsh, welcome, Mike. Nadia Prescott, Ottawa West, Four Rivers, welcome. One of our, Steve from Rainy River. Diana from downtown OHT, I think, DOHT, Durham. The acronyms. Kristen Pitzel, long time no see. Nice to have you joining us today from the OHA. Olga from NOHT, Essong. Steve White, Marjorie Conan, welcome. Welcome, everybody. Please continue to type into the chat. Let us know where you are coming from and introduce yourself so that everybody can see. It's one of the only ways that we get to see everybody at the same time. Welcome, Ashnor from KW4, Auburn LaRose. Okay, I am really looking forward to today. We have an excellent event lined up. And a little bit spontaneous. So get ready to participate today because it's going to be fairly active. I am first going to acknowledge that I am speaking to you from the University of Toronto in downtown Toronto. And for thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous peoples from across Turtle Island. And I am grateful to have the opportunity to work on this land. And I welcome you joining us from your own territories to acknowledge the land from which you are working and its history. We always like to start off with a quick poll to let us know if this is the first time you've joined us. So here we go. This is an easy, just let us know if you've joined us for a webinar before, yes or no, this is your first event. Please click in, and I look forward to hearing from your participation here. Thanks, that I see the results are showing, not the poll. That is right. Here we go. Now we have the poll showing. Thank you very much for that little note, Marjorie. And here we go. Oftentimes we have about 25–30% joining us for the first time, and after doing this for a few years with a couple hundred people on every time, I always wonder, how is that possible? But it does seem we do manage to attract new audiences, which we're always keen to do. So I think we have most people now have shared in, and to share the results back out. This time we have mostly returning people, 88% returning, and 12% are new, so welcome to those that are joining us for the very first times. And I am very excited to have everybody here. Okay, and so now let's talk a little bit about what we're here to talk about. So you will find in a few weeks, it's currently an embargoed version of this report, the Ontario Health Team's central evaluation for our developmental evaluation report that's coming out. And it really talks about the evolution of Ontario health teams over the past period of time. And led by Kaylee, who's currently on mat leave, but also co-authored by the other people. We're all here today, Gaia, Alana, Ruth, and myself, to talk about what we have found by spending some time with some of the OHTs and having a discussion around how they were developing, observing, and really seeing from the ground up what's been happening in the world of OHTs. So are very delighted here to share with you my colleagues Ruth Hall, Gaia Mbuldinia, and Alana Comiso, all here to talk about the results from the developmental evaluation, and then to engage with you in a World Cafe style discussion about these findings. We know from 6 teams what's been happening, and we wanted to have a sense of how widely these results are shared. So without further ado, I'm going to invite Gaia to Dr. Mbuldinia to come on and share the overview of these results. And Gaia, you can just tell me when to advance the slides and I'll do just that.
Sounds good. Thank you, Walter. Okay, so perhaps move on, Walter. Next slide, please. So I am going to essentially take you through the work that we've been doing over the past year through the developmental evaluation that Walter just briefly alluded to. And that we did, but basically just 6 OHTs. And I'm going to give you a quick overview of how we collected data, analysis, and then key results and some recommendations, both for OHTs as well as for people at the system level, so policymakers and so on. Next slide. So we are, of course, supported by a much larger team than just the 4 of us that you saw just now, and we've all got different sorts of expertise. We're focusing right now on work led by the qualitative team just for this presentation, but as you know, we do have a rather robust quantitative team as well, and you'll be familiar with some of their work if you've been a regular at some of these webinars. Next slide. Okay. So developmental evaluation is essentially an evaluative approach that uses data derived through embedded research to understand and support OHT development. Well, in this case, OHT development. And it has 2 aims. So first, it's, we were trying to understand, study, research how OHTs are developing. And secondly, we wanted that to be actionable, right? So it aimed to transform that research into action to support OHT development. Next slide. Okay, so 6 OHTs were included in the developmental evaluation, and there were 3 main criteria that guided selection. The first being geography. So we wanted to represent different geographies in the province, and we included teams from rural, remote, and urban geographies. We were also looking for readiness to engage in the developmental evaluation, the DE. So we were looking to see if they had certain components in place. So, how they self-reported their team climate or readiness for change, for instance, through, first the results from the HSPN organizing for OHT survey that we did, and secondly, through a document analysis of the OHT applications themselves. And then secondly, we did also realize that participating in this work was not without effort, right, on the OHT's part. So they also had to be willing to work with us over, what ended up being a year. Next slide. So we started data collection in the spring of 2021, and we finished a year later. We use multiple approaches to data collection. So we primarily conducted observations at meetings at different levels of the OHT. So this might include steering committee meetings, working group meetings, and so on. And there were 5 of us doing this. So there was an embedded researcher in, each of the 6 OHTs. And this was, so it was Walter, Ruth, Ilana, Kaylee, and I. And we were all sort of assigned to a specific team. We also conducted a set of interviews, about 5 to 7 interviews with each OHT, and we invited a range of OHT members to participate in a journaling activity, a reflective activity as well that they did sort of over the course of the year. We also did some document analysis and surveys, so for instance, on provider and patient experience and so on. Next slide. So often in qualitative work, you go in with a question that you're trying to answer, but you typically don't go in blindly, right? You're usually looking at the literature because you're trying to figure out what theories or constructs are already out there that can sort of help you think through your through your findings and that you can sort of build on. So the CCIC framework, that's the context and capabilities for integrated care, that was one of those frameworks that provided a very loose guide for data collection in the early days. And then because the ministry had drawn up a list of building blocks to guide OHT development to its maturity, we looked at those constructs too, to see if they could maybe, make what we were finding actionable for OHTs. But, whilst these frameworks shaped our thinking, they were really not used as checkboxes. So we were most interested in seeing what our observations on the ground would bring up that was new, so an inductive approach to research, right? Because that really is kind of the point of qualitative work, so not to fit things into pre-existing boxes, but rather to see what new boxes might emerge, or, what lies in between the boxes. So I'm really just going to walk you through some of the highlights that emerged from our on-the-ground observations and interactions over time with these 6 OHTs. Next slide. Okay, so three of our key findings. The first being that OHTs were evolving at different paces, and each was at a different stage of progress in relation to key areas of development. Secondly, despite differences in evolutionary trajectory, there were shared contexts, structures, and cultures that both forwarded and frustrated progress across OHTs. And a third, there were overlaps, but also key qualitative differences between what OHTs were supposed to be doing, and the supposed is sort of enshrined in the ministry's 8 building blocks for OHT maturity. So there were sort of differences between that and what we were actually observing them doing on the ground, right? So what was important to them on the ground. Next slide. Okay. So first, the idea that OHTs were evolving at different paces. And this should not be particularly surprising because obviously each team is somewhat unique, right? They have different histories, different levels of pre-existing collaboration. They are located in very different geographies, each with their unique benefits and challenges. They had different attributable population sizes and so on. And some met with unexpected structural challenges, such as being asked, for instance, to sort of amalgamate with a neighboring geography, right? Merge with a smaller neighbor that perhaps had been expecting to be their own independent OHT. And another thing that contributed to the developmental journeys being different was perhaps the lack of clearly laid out shared policy level guidance, but more about that in a bit. And yet, despite these differences in evolutionary trajectories, there was a good deal of overlap in OHT parts across the 9 key areas rather that sort of emerged through our observation of OHTs on the ground. And the next slide should lay them out. Here we go. So these were the key areas of development that we observed for vision development being a key theme, really, that was actually missing in the ministry's building blocks. But all 6 OHTs spent a good amount of time essentially figuring out, what they were supposed to be about, where they were going. So all focused on, patient and partner engagement, collaboration, how to develop person-centered care, the role equity would play, and so on. But some emphasized some of these things more than others. And establishing governance. So one OHT was able to incorporate as a nonprofit corporation and set up a formal governance structure, but others were really engaged with relationship building and figuring out how to make decisions collaboratively. So essentially the work that had to be done before governance structures could be formalized. Third, strategic planning. So this was the work that went into actually materializing teams' visions, right? So how to translate your vision into something tangible that would make a difference to patients. And OHTs did this by drawing up sort of schemas of high-level goals and drivers, outlining strategic plans, pillars. But discussing this, writing this out, sharing it was itself an important extension of the vision development work, and it provided a roadmap for the next area, that being designing integrated models, right? So a few teams took this slowly. They really wanted to gather data, conduct research on the ground, really figure out what, where needs lay before designing new pathways. But others went ahead full steam, and they started piloting new initiatives almost from the get-go. And interestingly, these weren't necessarily the old teams, right? The teams with the long-established histories and so on. But sometimes just the doing itself sometimes helped people get to know each other and build relationships. So it works sometimes. Okay, the next 3 areas make an appearance in all integrated care initiatives. And these are, well, creating digital health solutions. So this involved working on sharing patient information, supporting virtual care, then engaging primary care. So primary care or physician councils were set up in areas where there was already a collaboration in the sector, and where there was not, just simply figuring out how to go about setting this up itself brought people together, right? Then partnering with patients and families. So all OHTs were moving or had moved towards a standalone patient, family, and caregiver council with representatives, who would then sit at leadership tables and working groups. So the last 2, funding and incentive structures and performance measurement, quality improvement, and continuous learning, we actually had the least amount of data on. And this was because there was a good deal of variation on whether teams even prioritize this stuff in the first place at the get-go, because many were just getting started and these weren't on the top of the priority list. As with funding, it mostly emerged as a system level challenge, and I'll get to that in a bit. So there was some variation across OHTs in terms of which of these areas got prioritized, which took a backseat. But despite this, there were certain things that helped or hindered progress across all these areas. Next slide, please, Walter. So some of the things that helped were, high levels of trust, shared values and priorities, making time for sense making and learning, alignment between organizational and OHT priorities, engaging partners, community groups, providers, and subsectors, and clearly delineated and distributed leadership and accountability structures, strong communication around key priorities, a prior history of working together, and human and financial resources, a dedicated staff team being particularly important here. So progress was frustrated essentially, by the absence of these things, gaps in these things. But in addition to that, it was also frustrated by these three things you see listed below, which is, unengaged stakeholders. And by this, I do not just mean, unenthused stakeholders necessarily, but also just stakeholders, partners who should have been engaged perhaps, but for various reasons, whether because of, policy or funding related challenges, maybe historical issues, and they were not. So for example, this might take the form of not being able to fully engage home and community care or Indigenous partners. So I'm just going to pick one facilitator and one frustration to get into this a bit more, and the arrows sort of indicate which ones. Next slide, please. Okay. So over the course of the past year, we observed OHTs navigating, striking a balance between planning work and implementing work, right? So between thinking and doing. So some OHTs, for instance, prioritize developing robust macro level cross OHT structures to support work. So work such as governance, right? Others worked on at the organizational levels, building robust partnerships, improving collaboration, and still others dove right into piloting small-scale initiatives that targeted subsets of their priority populations. The most important thing, however, and this is something that was not easy for all OHTs, especially those that were focused on getting things done as fast as possible, was just pausing, taking a breath, and perhaps resetting. So we're calling this sense making here, but it's really just understanding how and why people interpret the world and give meaning to it in the ways that they do. So taking time to understand the different lenses that people from other sectors might bring to bear on an issue, ensuring that how you understand things really is in fact shared, and if not, acknowledging those differences and trying to bridge them where possible. So it might become clear that not all partners have a clear understanding of how initiatives were aligned with broader OHT priorities. So just slowing down to take stock, to learn, iterate, engaging, challenging conversations really helped. And sense making and learning processes might include conducting evidence reviews, engaging with learning supports, bringing in external consultants, and so on. And it was really this work of sense making that resulted in the development of new ways of thinking and working, right? So it was a foundational work needed to move from discrete organizations to an integrated network. Next slide. So moving on to a challenge that was shared by all OHTs, and this was the need for clear and coherent policy and system level direction. So at the outset, policies and system level resources that were not overtly prescriptive, kind of allowed OHTs to set out priorities that were locally relevant. It was seen as sort of a good thing. However, it quickly became clear that OHTs were also navigating policy and system level sort of gaps and uncertainties. So they had to work around a system that did not allow for sharing of patient data across all sectors, a system that did not allow them to fully engage sectors such as home and community care. There were unclear reporting structures, conflicting information from the ministry, OH, regional OHs. There were CQIP indicators that did not necessarily reflect what was important to OHTs themselves. One of the biggest issues that emerged concerned funding, the lack of it when it was absent, and the way it was done when it was present. So for example, the onslaught of funding calls, right? So these often resulted in a lot of work for OHTs because they now needed to do the work of figuring out how to align them with their existing initiatives, or vice versa if they wanted to be really creative. And on top of that, there were typically small pockets of short-term funding. And in fact, the short-term nature of funding was a huge issue. So a robust staff team, for example, was terribly important to OHT success. and not knowing if staff members could continue for another year because of the lack of OHT funding renewals being in place kind of hit teams hard. And they're essentially being asked to engage in long-term work, population health management, essentially with short-term resources, and sometimes resources that did not always align with where OHTs saw themselves heading. Next slide. So lastly, reimagining the building blocks. So just finally, the building blocks as a refresher, these are the original 8 OHT readiness criteria that were outlined by the ministry back in 2019 in the original guidance document. And these set out what OHTs should focus on as they progress from year 1 to maturity. And it was described as a list of mutually exclusive and collectively exhaustive domains where OHTs would need to make strategic choices. Next slide. So while all these domains were certainly relevant to OHT development, having observed OHTs on the ground, we found discrepancies between how OHTs were meant to develop and how they actually did. And we found that the building block domains are not necessarily mutually exclusive. In fact, they kind of intersect and inform one another, right? So developing performance measurement and quality improvement plans, for instance, might first require work on strategic planning and model design. So as currently set out, the building blocks also categorically combine key areas of development. So building block 6, which is leadership, accountability, and governance, for instance. This is such a huge area that combines everything from governance, strategic planning, to primary care engagement in a single bucket. So it sort of risks glossing over the very different resources and activities that are needed for each one. And also acknowledging that certain aspects of OHT development can only begin once progress in other foundational areas has been made, may be reassuring to OHTs that are worried about not making inroads in some of these things. So all this to say that while there is certainly overlaps between the building blocks and what we saw on the ground, paying attention to the discrepancies is useful because they underscore the differences between the expectations of policymakers and the preoccupations of OHTs on the ground. Next slide. Okay, so we're moving on to recommendations. We're starting with OHTs. Next slide, please, Walter. So I'm just going to read these off. So OHTs needed to invest upfront work into developing a broad vision that is meaningful to participants. It is vital for OHTs to make time for sense making and reflection. Priorities should be locally relevant and meaningful, acknowledging provincial priorities. Communication with the OHT is essential, particularly in the initial stages. Attention to relationship building and trust should be an ongoing effort. So what all these suggestions have in common perhaps is the importance of a shared framework across all OHT members. So a collaboratively developed vision that is translated into locally meaningful and provincially aligned priorities that are then well communicated and revisited continuously just to ensure that everyone is still on board and understands things the same way, right? Might be the way to go, yeah. Next slide. Okay, these are recommendations from policymakers. Continuously reaffirm and communicate the vision for all OHTs, commit to long-term guidance and funding, improve communication between policymakers and OHT supports, revisit the building block framework to better reflect the different components of integration readiness and OHT's experience on the ground. So in essence, it's a recommendation that policymakers develop, communicate, and reiterate a singular vision to OHTs that shows the way whilst also acknowledging the importance of allowing OHTs to interpret that vision in locally meaningful ways, while simultaneously working towards eliminating the systemic handicaps and committing, most importantly, it seems, to long-term funding. Okay, next slide. Okay, so I think we're ready to hear from you. Over to you, Walter.
Yeah, great. Thanks so much, Gaia. What a wonderful overview, and I can see in the chat lots of resonance here. So we're happy to hear that while we weren't able to observe all of the OHTs across the entire province with the same level of depth at a number of these themes. So let's engage a little bit here and hear from you. So the first, we're going to do a few polls and we're going to have some open chat facilitated a little bit. So we're going to start off with these 9 elements that we had said we observed. They're sort of categories. And so the first one is, which of these elements that you think were most relevant to your own OHT? So let's go ahead with this poll right now and let us know if you can click on those elements that were most relevant to you. I think there may be a problem. Oh no, it's working. Great. And now, the evolution of maturity goals, actually, there is a significant alignment. The maturity goals for the OHT put out by the Ministry of Health in its origin were aligned with each of the 8 building blocks. And actually, we've reported in and thought about how each of the teams and each of these elements of activity do fit within the 9 building blocks, but obviously there's a little bit of overlap and a slight difference across how they get captured and encapsulated. But I think that we would say we think there's an opportunity now to reimagine the building blocks, as Gaia put it, but these are following some of the advances of how the OHTs are actually evolving. So let's have a look now at what people said here. And well, there seems to be a modicum that all of these pieces here are relevant to many of the OHTs. In fact, creating digital solutions, which is the lowest, is down at 39%. So all of these, I think, are resonating to various ways, and we are don't expect, as in the chat, everyone to be working on everything all of the time. That's not possible. So I think that this certainly resonates there. Okay, well, that's great. So here I'm going to come around and pop up another poll. So this one now is going to ask about some of the challenges that we had talked about, and so if you could let us know how you've experienced any of these challenges. So these are some of the challenges that we had observed within the teams. And maybe if you could click in, again, this is a multiple, you're going to select all that apply. Which of these seem to be most relevant to you? I see that people are popping in now. Where did you have challenges around unengaged stakeholders? Did you find the reporting requirements and funding calls not aligning with your local priorities? Uncertainty about home and community care? Which of them? Lack of assurances about funding renewals. We certainly heard that from some of our teams over time, creating some uncertainties. And then COVID itself, for some people, it was an accelerant, and for many others, there were challenges resulting from that. So let's continue to allow these to come in. And I think we are just live it a few more minutes. There's a lot of options here. Sometimes the polls, if you have too many options, you run into challenges on letting them stay. So I'm going to share these results out. And so let's have a look here. Well, I mean, again, actually, all of these are resonating with many of the OHTs. And interestingly, actually, COVID-19 is the least of the biggest challenges around the OHT work itself. So let's take that. You know, I'm interested. You know, uncertainty about home and community care fairly high. Very high in the lack of assurances about funding renewals. That created considerable instability, and also I think some of the workforce instability amongst some of the core team members. We were seeing as to whether they could be retained, and hard to find quality talent for people on very short-term contracts. So I'm interested, you know, we've highlighted these ones that we experienced, and that these ones are also applicable. Thanks, Kathy, for noting in. Force us to narrow down then, selecting a lot of these challenges. So let's hear from you though on some of the challenges, and I'd like you to use the chat now because you experience things differently than we may have observed. So come in and let's hear what you've been experiencing. And I'm going to take the poll result down and then open it up, and let's have a little bit of discussion here. I'm actually even going to stop my share so you can see me again, along with my colleagues. Hard to hire a strong core team with limited funding, absolutely. And lack of clarity around the home and community care services from Ashnor and their ability to participate in the OHT work. I think we definitely heard from that primary care can't be the cornerstone when they're burnt out and not organized. And I think, you know, there's always on multiple sides, a strength in one side. Excellent primary care engagements are a cornerstone, but when they're very burnt out. Dennis asking about the provincial governance model. I think we have heard that there is some advice being developed, and how prescriptive that is, I think, is still to be determined. Elizabeth Changay noting again, resonating from an earlier comment, hard to hire and retain quality human resources on short-term contracts, very much. Top-down deliverables, taking away the bandwidth to act on identified local priorities. Thanks for that, Wendy. Engagement from partners with specific requests to complete deliverables, yes. I'm seeing primary care again. And I heard primary care a little bit earlier. I wonder, Ilana, you were in a couple of the OHTs, and Gaia, I know we heard in one of the OHTs, they had built up a little bit of a governance council. I know that I was looking at primary care in one of the OHTs, and they were very engaged. They had some support, I think, to bring the group together. But fundamentally, as we also saw in strong patient-family engagement, having a resource that was part of the OHT that was consistent over time to support the development of a network for primary care was quite influential. And then having an ear to what primary care, what their pain points were and how the OHT could help solve them was also a really key piece to engaging. But I wonder, Ilana, Ruth, Gaia, and if you have something around how you saw primary care engaged in the OHTs that you were watching.
I mean, one of the things that we observed was primary care being actively at the table, and not necessarily physicians, but primary care organizations. So family health teams, community health centers, or nurse practitioner-led clinic being actively involved in the steering and leadership. That created a base that sort of galvanized other primary care models and primary care physicians to be able to connect to. So that was a sort of a strength to support primary care engagement in the OHT and some OHTs.
Yeah, and there's an interesting piece, flavor from Anita here, of while we have primary care engagement from community health centers, family health team executives, and the nurse practitioner-led clinics, limited engagement with physicians themselves. And I'll say from the OHT, when I was talking about how that primary care engagement was successful, it was with the physicians themselves. They were co-leads, there was a committee, there was an very active committee, and they were putting in solutions related to things like, well, I mean, some of the pieces related to things like vaccinations, some of them related to supporting online registration, some of them supported access to a program called SCOPE, which is a primary care support program with access to specialists, usually residing in hospitals, to support those primary care. And so to Sudha's a point that if the OHT becomes a catalyst for a program like SCOPE that helps support the primary care physicians, it's about being that catalyst. But I entirely agree that there has to be a value, a clear value proposition. I think, Ruth, I'm quoting you now, I think, when I say that there has to be a clear value proposition for primary care physicians.
I think also maybe there's some geography there at play too, in terms of level of engagement of the actual physicians, with the resources being less plentiful in our remote regions in particular.
And I think, the funding stability around some programs too. Ashton was talking about KW4 really liking SCOPE, but the money running out. So how is they sustained? And I know with the SCOPE program before, a couple of years back, thinking about, what is the business case around that kind of an intervention, so that funding can be acquired and sustained.
We're seeing some chats around a comment made by Ashna around OH funding not actually being sort of directed to the needs of OHTs on the ground. A series of people sort of echoed that comment. And also an interesting comment around EDI and AR work that came up in our evaluation too, and how OHTs need to be able to do equity-related work in their local context differently. So I don't know if those are areas that we might like to capture.
Yeah, and you've also, I think, Alana, alluded that in different geographies, equity plays out in different ways, right? So like in downtown Toronto or Toronto or larger GTA area OHTs, ethnicity, racial can really become quite important. But then in some of the more rural areas, that may be less in magnitude of an issue than other social determinants, I think. Is that about right?
Yeah, sort of mobilizing equity to understand your local context and address the inequities rather than take a kind of one size fits all approach, which many OHTs are trying to do. They just don't have the tools and the resources, we've heard, to do this as well as they'd like to right now.
Yeah, okay. Wow, this chat is very active, and I really appreciate that people are actually sharing back and forth, resonating the ideas amongst yourselves. Jodim has a fairly long note here around tensions between organization goals and the OHT goals. That's a key piece, and actually we'll come back to this a little bit when we revisit governance in a few months, because we actually have asked the leadership teams about their balance between their prioritization of the OHT's goals versus their own organization, because that can play an important role in network governance, and holding that space in multiple perspectives to enable breakthrough sense making in the landscape. Really, that is, Jodim has spent a lot of time with OHTs, particularly in early days of coming to common mental models and shared purpose. And Jodim is my mentor in delivering events like this today. And we're going to have a chance to get together again, actually. So everybody pay attention. Jodim and I are going to be hosting it next month on this forum. So look forward to that. I think, Monroe's point here about the times and expectations being unrealistic, we have to accept where people are at, and they're moving at different paces. Depends a lot on the types of relationships and the foundation from which they're building. And if they're building on a long history of partnerships, they can often accelerate some projects faster than others. But every OHT we've seen has areas to improve and build strength in. I am now going to come back and move us ahead. Those are some of the challengers, and move us ahead now to a little bit more on some of the opportunities and enablers. So we had identified a number of enablers on Gaia had pulled these together, and I've posted them again here. And so we're going to ask you now around some of these enablers, and we have a number of them listed that we saw really key ways and approaches that OHTs. So let's hear from you now around these enablers. Which of these, and you can check more than one, have really been, and I'll say, most important to you and most activated, right? So if something wasn't really necessarily being paid a lot of attention to within your OHT, then maybe hold off and just talk about which ones actually have been most important to you in enabling OHTs. So come along and pick out the ones. Like, did you experience high levels of trust? Was that important? Did your OHTs really, all the members have shared values and priorities across the organization's individuals and teams? Oh, it's only allowing a single select. Well, that's how it's going to go for now, for today. I don't think I can change that quickly on the fly. Maybe we'll come back and you know what? Here's what I'm going to do. I'm going to take this down. We're going to go to a chat, and I'm going to come back allowing multiple to select. That I can do. Let me go ahead, and we're going to open up the chat first, and then I can probably do a little bit in the background. So on the chat, and I didn't really need to take the that voice piece down. Let's have you sharing what other enablers or what enablers have you really experienced in your OHT, and I'm going to, in the meantime, try and do some magic and reset that. And I'll ask my colleagues maybe to take on leading some of this chat discussion. The SUDA identifying the role of the Patient Family Advisory Committee in promoting a change, and we've seen that. We had the North York team in Stories from the Field talking about how that was a real enabler for their team. And I'm going to go mute just for a moment and leave it to Alana, Ruth, and Gaia to voice through this while I go fix that hole.
And the interesting thing about enablers also is that some of this can just read as rather circuitous, right? As in where do you start? Because they're both enablers as well as where you sort of want to end up, right? So do you start with trust, or does something else need to be in place that's actually the enabler that sort of allows you to end up with trust? So I'd also be really curious about which of these things you actually start with, and why did you decide to start there?
There's a good comment about having an operational team, or what we noted as a backbone team in some of the OHTs, and this allowed a lot of those OHTs to make progress. Where I'm just wondering how many other people. Jim's comment was not made to everyone, so maybe we could repost it to everyone. Jim, I think you just made your comment to the host and panelists.
And there is also a lot that's not captured by this rather macro list, right? I mean, Mike Hinmarsh's comment about where the heck are the coaches on this list is, is relevant. There's a lot of stuff that didn't make it onto this list. So OHTs helping each other, for instance, was huge, right? So this is really sort of, yeah, high level stuff. So do tell us what we've missed. No, it is true though. I'm like,
it was a salient factor. OHTs that had the bandwidth to work with learning supports were able to make progress in areas where other OHTs weren't. And we observed that, and the report highlights that, but not all OHTs had backbone supports in place to take advantage of the learning supports that are in the system. So it is a worthwhile comment, Mike.
Comments are coming in fast and furious. It's hard to keep up with them all.
Having your patient partners as key decision makers, Kathy's noting here. So everything is co-created from the get-go.
I think that's really fundamental and quite key as well. And I see Mike getting a shout out as a support and advisor, Mike Heinmarsh. So that's the coaches, I think, right? And people who have been able to avail themselves of those coaches, the consultant support to do collaborative team building also being important. It's interesting, Jodine's point here about telling the OHT impact story. And I think that getting people to also galvanize around patient stories and provider stories too are really important, so that providers know the value of being engaged. Having a decision-making framework, understanding who makes what decisions under what conditions, and I think that's very, very helpful in advancing some of the teams as well.
It would be interesting, Wendy, to hear more about how you came to your decision-making framework, because that has been a challenge for some OHTs, is how to even sort of operationalize the framework. Yeah,
and particularly we've highlighted some results that many OHTs are really aiming for collaborative decision-making. And collaborative decision-making doesn't, it's not the same as consensus. And so there really is an opportunity to think about, how do you make decisions? How do you allow everyone to express their voices, and to have that opportunity to try and come to agreement as much as possible on that. And so that's can have lots of discussion, Wendy's saying, is how they've talking about some of those opportunities. And so maybe actually we could start around some sharing of, I wonder if there's a COP where that would be very applicable. I know we help one, we lead one with around performance management improvement. And so perhaps one around governance. And if not, we can kind of take that on. I've got this poll fixed up again now, actually. So I'm gonna go back to it and try and bring it up. Okay, so this time it should allow for multiple choices. Now, which of these enablers are able to, are important and have been important levels of trust. Share, continue to put in the chat other ones, but let's get your input here, because we're interested in, you know, we've watched 6 teams, you know, and so it's really important for us to understand beyond those 6 teams, which of these and how many of these are relevant to other OHT representatives across the entire province. There are 51. And just this is a lot of options. Now that there's more than one option, there's a lot of options to select. So we'll just give people an extra minute on this one. Which ones have been most activated and most important in your Ontario Health team? All of the above needs to be an option. We're making you check through all the boxes if every single one of these has been activated in your OHT, because I think we do agree that that these have played some role, but which ones have been mostly activated? I think we're really keen on that. We'll leave it open about another 15 seconds. And sorry, we didn't have an all that apply option. I do understand the value in that. Okay, and there's still a few people trying to check in. So I'm just going to say, regardless of how many options you now, if you've checked any of the boxes, please hit submit so that we definitely capture your input, even if you haven't checked all the boxes yet that apply for you. Thank you. And so I'm now going to share these results back out. Okay, so you can see, again, what we've seen in these 6 teams are resonating, at least to some degree, in all of the OHTs. And I honestly am not surprised to see that making time for sense making and learning is the one that has been most important and activated. And I think people are so busy. There's so many things to be done today and so many more things to be done tomorrow, that to think about taking the time to get people together, to have the time to understand how we even use the same words in different ways, how we use different words to mean the same thing when we don't have a lot of time to be together is a real challenge. So I think taking that time, we've seen that as a real enabler. I'm not surprised to see that less activated. Certainly engagement of partners, community provider groups and subsectors being the highest one here, high levels of trust. So I think we're getting some resonance here, and I think to the team that what we have seen within the few OHTs is also being experienced elsewhere across OHTs in the province. So I think that is that's good resonance for us to be able to do that. Looking back at the chat, there are a few extra pieces that kind of came in. Having a strong and committed backbone team and implementation, yes, that wasn't one of the ones we did, but we have seen that. Including internal expertise on population health management, and that was generated through an OHT fellowship. I think Mike also noted that some of the teams taking advantage of the OHT fellows, and funding being another huge enabler. Okay.
There's an interesting qualification from Leslie Walter about decision-making frameworks and how they work well when you know what's coming. But when you're trying to make decisions that you don't anticipate, that the framework itself doesn't work. And I think that's a really important qualification, because it speaks to both like some of the need for sense making and learning how to make decisions that come up in real time versus things that you have time to stop and sort of plan for.
Yes, I think that's we actually also saw that a little bit in the area of governance, that many of the teams that talked about shared governance and decision making had not yet taken on some of the more difficult decisions. So they'd worked to areas and made decisions around things where they had clear and full agreement, and not a lot of not as high risk. So they hadn't come to decisions where money might actually move between different organizations or result in reallocations, that those were going to be much more difficult, or how to set priorities where interests might conflict with organizational interests. So I think that's not the same, but also in a similar vein. It's interesting for some of the comments now, and I'm not sure if our colleagues over at the ministry are online now, but access to the OHT fellowship program is, as a sidebar, comment here about whether that can be equitably distributed. I think across, there's more of an effort this round. I think the OHT fellows going up more into the northern areas and creating a more focused program to support that, I think has also been but wanting to make sure that there is equity and access to particularly some of these resources. I know that we produce a lot of data, and on the data side, we have found quite a bit of variability in the capabilities and capacities for OHTs to absorb and use that data. And certainly when there was a fellow present, it was enhanced for us. So I think that French or bilingual definitely being important. Capacity, right? This is hard work, and it's not something that we have a long track record in skilled people having done the work before. Population health management is relatively new to this area. And we want to make sustainable changes to local health delivery, as Noor saying, having to decide who decides the what and with what resources. Getting a thumbs up, I think, from Elizabeth Tanguay. Let's go on to one other topic here around a chat and discussion and engagement that we came across in our OHT, and that is this idea of understanding what are the most important areas to move forward on. And then we're going to actually step into a World Cafe. So I just want to think, like, what do you think are most important to OHTs to invigorate action? And I'm going to say that we're going to set out as a goal here to improve population health and patient and person-centered outcomes. It should really say person, not patient-centered outcomes. If we're thinking about population health, it is not only about the patients, it is about the entire population health. So let's think about areas to move forward. What areas do you think are most important for OHTs? Your own OHTs, other OHTs. This allows everybody to be involved in this discussion. So how could we have done this differently if we could press replay as a question raised by Jim, or just if you could press start now from where you're at, because where are you going to step first? Let's see how you'd open that. Funding provided teams to act on identified local priorities and population health needs. Time and space to focus on care redesign that actually improves health outcomes. And funding for care, not just for planning. So thinking about how are budgets and what is going to actually be available to undertake. So if models are designed, how are they supported and funded? And I know that there are some fairly targeted areas that are now coming out related to heart failure, which is not really, I don't think, wasn't really on the focus area of many OHTs' agendas. And so how does that align with those local priorities? It's that balance between provincial priorities and local priorities. So if you thought, now we're starting to get some of the comments in from individuals. So let's see. Emphasizing the OHT work over your own organizational work. Mike's idea around, having a clearer picture of a future state. What does a mature OHT look like? So people have a common vision and shared. Needing the ability to fund activities, allocate funding, Monroe, that improve population health. Yeah, really thinking about that population health aspect. I think that's what we're trying to drive at here, and person-centered care. More bottom-up than top-down planning. Focusing on the priority population work. Truly believing in the idea of attributed populations. Sudakari, Jodim, again, align strategic goals and the strategic plans of each organization. I think that gets back to how do we get this alignment between your own organization and that of the OHT. And we actually had a guidebook which we can point people to, a link after. We came out at the outset of OHTs with four guidance documents, one around patient engagement, one around collaborative governance, and then we had a few others around leadership, and also provider engagement and how to focus the activities of providers. they're a little bit buried on our website because they're back at the origin of OHTs during the application process. So maybe we can bring those back out and highlight them a little bit. I think they are still relevant. Key issue, needing more family physicians and don't having a mechanism for addressing that. I'm not sure, Cynthia Lacroix, if that is just needing more physicians in your area or involved in your OHT. I think both are probably applicable as we hear words across the province. Some education around the OHT model that needs to be done as OHT teams continue to be built up. So how do we think about attributed populations? How do we think about population health management? And maybe like a routine, accessible training program. There is the advanced program, but it's once you've kind of taken it, then I think it's hard, if you, especially if you have turnover within your leadership and things like this. And we do know there has been some leadership change. So that's also a sustainability issue within the teams. Kathy Peters from Burlington, needing to build on their strengths of trusting relationships across the providers and sectors to accomplish together what we can't do alone. That's absolutely the value proposition in an OHT. So what are the things that you can do together that you are just not nearly as well prepared to do alone? Oh yes, yeah, training for Ontario health staff. The people that are supporting this work are needing to learn what it is that they're trying to support. Yes, absolutely. Kathy Peters, again, the Ministry of Health removing some of the policy barriers. Maybe there's like, a specific policy barrier you think you've run into. I know we've run into some around the home and community care. Maybe there are some offers. Deborah talking, Cynthia's comment, allied health providers, nurses, just needing more. Yes. Oh, Jodine, we're going to miss you terribly. The recording will be up after, and you can catch what the World Cafe let us in, because we don't even know what direction that's going yet. And so actually, maybe on that note, we'll head into the World Cafe a little bit. Okay, and so let's head across. I'm going to come back up to our slides, because I'm going to talk through how we're going to do this now, but we are definitely going to stay quite engaged with you. So what's the purpose of this World Cafe? And we've already been doing a lot of this, but we're going to actually crowdsource the topics. We gave you some topics. Now you're going to tell us which ones you want to focus on. And we have a few options here. So our purpose here is to continue this informal discussion around talks, to ask questions and shared strategies. And again, we're here doing what we've been doing in the last 20 minutes, 15 minutes, which is facilitating the discussion rather than specifically providing advice, although you can certainly ask us questions along the way. So here's what we've done. We've picked 6 of the topics that, in collaboration with the 6 teams that we had already had some discussion about our early findings about, and which of these should we dive deep on now. So we're going to spend a couple of minutes and dive deep on a couple of these. So I'm first going to go to this poll, and it will allow you to choose and I'm going to ask you to choose up to 2, because we really want to get a priority setting activity here of which ones you are interested in as a topic now to dive into a little bit more today. So let's see what people say. You choose just one if you want to just choose one, but up to 2. I don't want you choosing all of these because otherwise we're going to have a hard time setting priorities. So let's see what people are most interested in carrying on the discussion about today. Again, these are all themes that came up in the developmental evaluation, and we're super keen to have a little bit further discussion down into some of these areas. So let's see. We still have quite a good audience, over 120 people still online here. Sometimes at the hour we lose about sometimes a quarter. That's about, I think. Okay, it looks like people have kind of landed here. We're going to have to pretty close on some of these. So I'm going to end it, share the results back out so you can see here that it was very, very close amongst a couple of these, but I think there are three here that stand out a little bit further. Physician primary care engagement, policy, legislation, system supports, and capacity building, governance. It was governance, leadership, and decision-making, and capacity building and development. So we're going to start on capacity building, development, and sustainability. And then we'll come back to governance as long as we have time. We could clearly choose multiples of these. So let's go now and come out to this area of governance. And so I think I have. I think it was capacity building was the highest. So let's start there. So what are the issues that relate to this topic area for you? So a couple of them, that we had highlighted when we were looking at this, just as some examples, and then we're going to really understand what issues you're confronted with and challenges, and what opportunities are you taking to advance in this area. And so this is also about sustainability. So what did you do and to balance, for example, visioning, priority setting, capacity building versus just getting on with the work? That's part of this area. And when you kind of think about it, what has driven you in the direction you have in the model of your OHT, in which selection of your priorities? And as you think about your future expectations, what's standing in the way? To what extent have you been able to navigate around barriers that you've found? So around these pieces here, capacity building, development, sustainability, issues you're confronted with, and challenges related to this topic. So let's hear what it is that you have found, and then we can share a little bit about where some of the solutions might be on this topic of capacity building, development, sustainability. We've highlighted some of them. They've come up through having the right people on the backbone team, finding people with multiple languages, finding people who are willing to operate in different parts of the provinces, bring capacity to different areas. So if you can, pop into the chat your ideas around this. Guy, I don't know if you want to add in any other prompts here in this space.
I was just busily doing a quick search of the chat for the word sustainable. And yeah, it just, some interesting thoughts have come up already, right? So someone was saying that, I think it was Leslie Wells, 750K per year is not enough money to support this work, even if sustainable. So I think it goes back to the structural stuff. When Lee Smith was talking about deliverable, about sustainable plan is somewhat distracting at this early level of development without a clear understanding of the ministry and Ontario Health's future vision for OHTs. So yeah, it is interesting having a conversation about sustainability amongst ourselves, which perhaps beggars the question, is there anything that we can do, leaving that stuff aside, acknowledging that it is needed? Is there something that we still can do on the local level to forge ahead?
Yeah, and now I'm also seeing some of the more recent ones being added in here. Struggling with building a plan for sustainment when it's not clear on the provincial plan for OHTs. And so, trying to see, if funding is limited, where the terms are short, how do you really build that sustainability and the energy? I think that I'll say our colleagues, I think, are at the ministry are somewhat cognizant of that, and then we really need to ensure that it also makes its way into the political realms as well, if it's going to be sustained and supported in the ways that you're certainly experiencing.
And navigating competing priorities has come up numerous times in different ways. How do you prioritize one thing and move it along? And so most recently, I think it just came up, but it's been mentioned several times.
Yeah, and Nadia is wondering, the value of this discussion amongst colleagues. So this is not intended just as a support group. We generate. There are colleagues from OH and the ministry on the line as well today, as there always are. And but we also take these directly to the implementation branch for the Ontario Health teams, and also to the OH group and the value-based care who are responsible for this. And they hear directly from us around around the findings. We've already discussed a little bit some of the developmental evaluation findings. The results of the polls here today and the results of these chats are also brought into those discussions, so that you can know that the people who need to know kind of that grassroots, what's happening out in the field, they also get this material and these messages. So
and there's this tension between committing time to strategic planning, which we saw, and Wendy is echoing here, that helps you move forward on shared priorities, and not having the time to spend on planning as well. So this is a theme that has come up in our evaluation, but we're seeing in the chat as well.
Yeah, but also support for that. Cheryl Davis saying good planning is key, shorter and long term. So finding the time is a challenge, but the importance of it is important. And the level of funding, whether that's sufficient in this space. I think it's about how you're allowed to spend money too, and which money you're allowed to spend in these areas. SUDA is, seem challenging a little bit about the time spent in planning versus activity, and we've certainly seen the challenge. And one of the issues we've actually highlighted is that balance of the work of implementing new pathways and actually working on projects together. In early days around the OHTs, we had had a webinar, I think it was February 2020, on population health management and how we were seeing this operationalized around the world. And I remember the example of the Netherlands, of how they were actually advancing. And their emphasis was on developing and implementing collaborative projects together, and going right to that kind of ground level implementation side, so that it was not only planning, that they were actually starting to work on the ground implementing projects. And sometimes it meant that they implemented smaller projects rather than very grand ones, and scaled up from there, just to ensure that they actually had a sense that they could accomplish things together. And that actually generated a lot of trust amongst the partners as well as generating enthusiasm. Collaboration with other OHTs being key to help address the challenges. And part of today, is thinking about what are the other OHTs doing to find out, are there common areas? And we think that maybe there will be an opportunity through some of the regional tables, but maybe also actually OHTs can meet each other through the communities of practice that aren't regional boundaries to find areas of interest. So if you're implementing models for palliative, or you're interested in models around mental health, to learn from each other around those focused target populations as well. I think that that's also a real opportunity. Yeah, knowing that OHTs, ensuring OHTs can be productive. And Marjorie, I'm gonna think that by being productive, you mean actually producing health and engaging in activities that that bring together services for people. We've had, in stories from the field, go back and look at some of the webinars, told some of the stories. And I remember we had East York, North Durham talking about some of their implemented models and how they were going ahead, involving people, I believe, from home and community, the hospital, as well as primary and community care in that approach. Yeah, so I think, we had done some, Wendy Smith asking about some shared planning. We had done some initial summaries. We did have access to the original applications around some of the priority areas and highlighted some of those. We might actually be able to create opportunities for, I think maybe even now, because some OHTs I think have gone back to strategic planning and done a little bit of resetting to talk about where the priorities are now. Some have gone back and said, no, we had the right priorities in the origin, let's go ahead and get them done. And some have said, well, actually, I think after the past few years of reflection and thinking about where we're at now, we might choose a slightly different area to work in. So maybe an updated list, and then allow those opportunities for sharing those topics. Today, and these kinds of engagements are also an opportunity to share what we're up to. It's a question about doing the strategic planning before governance changes come out or home care changes. I think, strategic, getting people on the same place. And I doubt that the home and community care is probably going to have some particular regulations around it, I expect, because it's a service that has to be provided and paid for. I would think that governance is probably going to be more around suggestions and principles. I'm not sure there'd be so much restriction on the governance note, because some teams have already moved ahead. I mean, we've had Hamilton talking, and they've actually gone to a not-for-profit incorporation. So I think that I would be surprised if to find that was like offside. I don't think the government has wanted to be overly prescriptive about the governance, and still watching to see what's evolving as best practice for OHT. So I would not hold off on strat planning until everything is done, because I think all of this is an evolution, right? I think, Gaia, you've put it nicely around seeing things evolve over time. I think that's been your impression as well.
I think so. I mean, my impression has also been there's been a little bit of, where do we actually forge ahead, given that things might change upon us at any time, and then it's, we'll just have to go back and reinvent. And I feel like different OHTs have made calculated decisions about, where is safe for them to go ahead. And I mean, Hamilton, for instance, perhaps it was a leap of faith doing that, but, they did that whilst perhaps, taking it slow in other areas, right? So, I mean, it's always a bit of a balance, but it worked. It seems to have worked for them. Perhaps it might not do so for others, but, other people, other OHTs, I think, went right into, let's change pathways. And Hamilton, for instance, and that was the OHT I was embedded in, they kind of wanted to take that slow, and they wanted to do that ground up, right? Let's go in there and do the research. Let's look at what the literature says. So yeah, just different pathways.
And yet what we found was, regardless of where people started, they did overlap, because you could only go so far building care models without having to kind of revisit your long-term planning. And your strategic plan was only a plan until you started to implement it and see what was feasible. And so this really productive kind of tension between planning and doing and learning as you go, and seeing all of these things as living attempts, not as written in stone, was an important takeaway from what we saw, I think.
Yeah, and there's a question around the governance guidance being a summary of existing structures rather than guidance of which direction to go. I say, I think that we will give this the summary of existing structures. And if you come back in January, we will describe what the existing structures are: membership, turnover, decision-making of the existing structures. But our goal is, I think, to be a little bit guidance as to what are some of the trade-offs and some of the contingencies of which governance models work best under which constructs. For example, if you have relatively new partnerships and are building new relationships and don't have a very strong supported history of trust, then it is very important that the governance be inclusive and have many members, and that decision-making is also distributed amongst the many members. If you have high trust, smaller teams, you can actually delegate some of the decision-making in the governance model. So it's a contingency a little bit, and we are actually looking at some of the models around the world for network governance. It is an emerging area. There is not a golden standard to know what network governance is optimal. So we're looking at what the UK is doing around their integrated care systems, what the Netherlands have done around their networks, and bringing that here to Ontario as well. So stay tuned. Come in January, we're going to actually have a focus on governance, including some people from those jurisdictions talking about how they've approached governance models. network, and they are a little bit ahead of us in moving in that direction. So I think that's going to be a real opportunity for us. Okay, I just catching up on the chat a little bit. Yes, I really like Jason, can't remember if it's Cabell or Cable, I think it's Cabell, apparent that many of the OHTs, certainly ones here today, agree on the current challenges, sustainability, progression of maturity, planning and care models, and moving beyond acknowledging these concerns to collectively addressing them. I could not agree more. What an amazing way to end off the part on the sustainability model. Questions and issues related to sustainability. I think that's really, really key. I think we had another topic that was highlighted around governance, leadership, and decision making, and so it seems that actually this has morphed a little bit into some of that governance discussion. Actually, it's interesting around the sustainability for the model. And so another topic that had been brought up was around physician and primary care engagement. So with the facilitators' purview, I think I'm going to come back and talk about come back to that topic, which was a very close third in our discussion. So just to remind people what that was around physician and primary care engagement. What are the issues that you're confronted with, and the challenges, and what are you challenged by related to this topic? And particularly, I think a number of people have talked about challenges. What I'm really interested in hearing here, and I think others would agree, is have you seen things in your OHT where physician and primary care engagement, and maybe a little bit of an emphasis on the physician engagement, because people did talk about being able to organizationally engage with primary care through CHCs or family health team management, but that actual physician engagement, and it doesn't have to be limited to primary care physicians. We've seen in a few OHTs, as an example, where specialists have been brought right into the leadership tables. And so don't be limited when we say that. And other providers too might be very important and more critical even in your OHT, perhaps in engaging. So I'm interested to hear what it is that you've been able to succeed at. And if you haven't, then fine. Let us know also what maybe you're hearing on support. Wendy talking about, she's noted significant increase in physician engagement following actioning on initiatives that directly impact the work of the front line. I think that's true. Like, how is it that the OHT is going to support the work in primary care? And Ruth's asking for an example. I think that's a great question, Ruth. Can we be a bit specific? I mean, where I saw, and because I did observe some of the work in primary care, was around where the physicians had decision making over what activities they would undertake, and they were supported by their OHT secretariat and backbone to apply for funding, to develop new funds, and thereby they were able to put some activities and some solutions specifically in place. Okay. Monroe, biggest issue around engaging is physicians exhausted by existing workload to spend time on broader priorities. I wonder, we've seen in some examples where during the pandemic, primary care being brought in to help, being supported in their vaccinations work, and for the OHT to help in supporting them directly. It's about supporting them to do the things that they still get to practice the areas that they need to practice in. You're not wanting to take them out of the picture, but allowing them to do the things that they feel they can create the greatest value for. And Nadia talking about a one-on-one approach with a focus on where we can actually support them. And I think that's a listening exercise as much as anything. And if the OHT could, fund a nurse to help them provide care. I think, if these are shared and pooled resources, again, you don't want to build out too much inequity even amongst the physicians within your OHTs, right? So how do you create shared resources that are shared across physicians to engage them? Wendy Smith asking primary care providers to highlight the most pressing issues and addressing HHR issues as well. And I think, Alana, we did some work in physician engagement attached to teams. And I wonder if some of the findings about engaging physicians where they were being given an opportunity to have patients receive additional care, were there any challenges, do you remember, in having the physician buy-in for those activities?
I think there was a lot of resistance at the outset because it sounded like more work. And so a lot of one-on-one kind of listening, gently inviting physicians. And when they were able to see the impact on their workload, on their patients, that galvanized buy-in. And when physicians were able to talk to other physicians about the impact it had on their practice, that kind of even accelerated it. But there was no substitute for the early listening and one-on-one work, and the really trying to really be respectful of how much added burden at the outset this type of work can feel like.
Yeah, I think, and some talking about, Ben, noting that even within family health organizations, so investing in backbone supports to support and help change management, so you're not actually contributing to more burden and activity. I think that's actually aligns a little bit with what you were saying there a little bit too. And the other pieces, there are issues related to compensation, and we need to know like when and where that is important and when and where that is appropriate. And I'll say Marcia's point here about having strong local physician leadership and champions who understand what the challenges are from the physicians and speak to it from that perspective can be really helpful. And I know that we saw that activity, very successful strategy employed in Northwest London in England in their integrated care service. And that's one of the cases that we talked about in population health management as well. In our review of international models that it implemented. Hosting in-person town halls, Farzan says, to bring physicians and nurse practitioners together under keynote topics that are most pressing to them, as an example, mental health and addictions. So I think that's, and I've seen that used elsewhere too, to have a physician forum and then crowdsource the topics that are pain points, and hopefully ideas that provide solutions and opportunities for some of their work. And then the OHT becomes a catalyst to supporting that work. I've seen that in some of the OHTs. You also actually have to create the forum for the physicians to be together. Many OHTs didn't have that originally, and it's a bit of work to actually start to actually create those networks even in the first place. And I think that crowdsourcing becomes quite important. Victoria talking about different ways for physicians to gauge research, quality improvement, small ad hoc, curriculum development, many different ways, right? And not being entirely certain about which ways are going to be most successful, and different ways probably more successful than others. In Frontenac, Lennox, and Addington, Anastasia talks about all projects having primary care physicians as leads, and the Primary Care Alliance and Physicians Council closely connected to that OHT. I think the executive lead, being a physician herself, can be quite important, and they're acknowledging that compensation for those activities is quite high and might be detracting then from other opportunities. Right, there's an opportunity cost to some of these. Wendy, we have an amazing chat here today. And Wendy Smith asking about whether we can get a copy of these very rich chats. Usually we just use these a little bit in the background to create some key messages. But I think that we can share these out. And I think we did do this once before. We will remove the names so they're not attributed to individuals, just in case the individuals felt that they were speaking in a different, although when you registered for this, we do talk about it being, anybody can join these events. And Willem asking, your name is very related to mine. I would say your name Uchik instead of Uchis. So thank you for running these incredibly engaging, informative sessions, because we all will be bumping into a lot of the same problems. And everyone's approach to solutions being so different really helps to have a space where we can share. That is what we hoped for. We've had a great opportunity here today with many of you, and actually, any success we've had here today is entirely because of you, because you came and you engaged, and thank you for sharing. So we are here the fourth Tuesday of the month. In November, we are doing one in collaboration with Canada. You can see me co-hosting with Jodine, and it's about engaging with community. And in January, again, we're going to do these once a quarter, not always back to back, but once a quarter. And we are going to talk about network governance, also in collaboration with Civic Canada. In February, we'll be back around population health management of chronic conditions. Thank you, everyone, for joining. If you have just 1 minute to spare, I will ask you to look at that QR code, pick up your phone, click on it. You'll receive a link from us tomorrow. Maybe some of the team could put a link into the chat as well if there is actually a link to this feedback. And it's just around, what if you gain from today, and also an opportunity to create opportunities for sharing. Very engaged today. We are thankful to have had the opportunity to share, to learn what you've been up to. Leaving this up just so that you can have that opportunity to zoom in on that that QR code. Real pleasure for us today to have had all of you with us, and nice to see people engaging back and forth across the OHTs as well. We had a lot of very engaged people today, and also I noticed a lot of the names. There's a link in the chat now for the feedback. It's only about 3 questions. And thanks, Jason, for coming and sharing your insights as well. You're all the experts in the field. We are just creating a facilitated forum from what we are seeing. Thank you all. Have a lovely afternoon.